Since I consider myself a very small fry when it comes to medicine, I try to talk very simple stuff, and I will try to prove that. When it comes to asthma, I think it doesn't matter which discipline we practice in. We all see asthma in our day-to-day life, and we try our hand to give the patient some comfort. Whether we are doing it in the right way or whether we can improve ourselves, we will see in the next 20 or so minutes. I've got only a few slides, but there are loads of questions which will come across from those slides, and if you permit me, I possibly will do it an interactive session, which it is meant to be. Unless you participate, this talk will fall flat on its face. So let's start. And what I'm trying to do is to give you some tips as to how things can be done very easily, but in the right way. Before, I will show you a case which is absolutely bread and butter case for all of you. But before I show you the case, I will do a bit of recap. And why do we need to discuss asthma? The reason is very simple. If you see the slide, you will see this is a WHO slide, but it's a bit dated, 2002, and you can see that chronic respiratory disease tops the list when it comes to communicable disease and its morbidity. And this is not all. If you add up few of those ischemic heart disease, stroke, and diabetes, and we know that diabetes, India being the capital, or is going to be the capital of the world when it comes to diabetes, you add up diabetes, stroke, and ischemic heart disease, and you still cannot catch up with chronic respiratory disease, which is way over the combined all these three, ischemic heart disease, stroke, and diabetes altogether. So we definitely have reason to discuss asthma and to try to treat the patients as well as possible. Now, this is the mortality. This is the same source, WHO 2002, and you can see that only injury supersedes chronic respiratory disease when it comes to mortality and communicable disease. Non-communicable disease, I'm sorry. So 80 to 85% of chronic respiratory disease in our country are due to asthma and COPD, and this is bread and butter stuff. We all see them in our clinic every day. Prevalence, and this is again, I think this is more than this. That was the last survey, and that's 300 million adults and children worldwide. Prevalence is 50% increase every 10 years. And we have, this is a very conservative estimate, which is about 15 to 20 millions in India. And this is what we all know. The central problem in all asthmatic is inflammation. And we have to address that. But that's about all when I said recap. Now we are, and this is the last slide possibly. And this is, I always talk about this. We must ensure that people who have got even suspected obstructive airways disease must have this spirometry. We have spirometry here, do we? Yes? Yeah. We all should be familiar with this, and especially those who are doing medicine. Doesn't matter which discipline you are in. Like we all need to do ECG, and we all need to be able to report an ECG. We all should be able to report a lung function test. And if you ask me any question, I will support my statement with reasons. But that's about it. And then we come to the case. And this case is absolutely bread and butter, isn't it? A 27-year-old presented with, do we have a, we did on that. 27-year-old, and this patient came to my chamber, my office, at about 9 o'clock. 9 o'clock in the evening, and he was about to collapse. 27-year-old, short as a breath, wheeze, can't speak in full sentence, and his pulse was about 110 a minute regular, and he had expiratory loci all over. Yeah. Do you see this patient? DNB, maybe. Yeah. Do you see these patients in emergency or outpatient? Now this patient, you are in casualty, and this patient walks in. Yeah. And so this is the main, the pivotal question that we have to ask ourselves. Are we going to discharge this patient from ER, emergency room, or are we going to admit this patient, or we are going to treat the patient in emergency and then send him back home? How do we do that? How do we do that? DNB? You do it every day. Please don't be shy. You do it every day. So, any idea? Yeah?
Hospitalization.
Beg your pardon?
Hospitalization.
Hospitalization. That patient should be hospitalized. On the basis of what? Because the moment the patient comes in the hospital, the expenditure will go up. Of the government, of course, and you and I pay for that. So, there must be some basis why you want to admit this patient. You are absolutely okay. I'm not arguing your decision. I'm asking, what's the reason behind your decision? The reason why you're saying this, because you are mentally, at least, trying to grade the severity of this patient, aren't you? That's what you're doing. That's why you wanted to admit this patient. Yeah? So it doesn't matter what the patient is, we automatically, that's how we are trained, to see whether this patient is safe back home, or whether the patient should come in. That's what we are doing. But we have a way, we have a method, there is a guideline, how we grade the severity. And it's nothing rocket science, you all know, but I want you to start practicing it in your daily life. And that's very simple, and I will come to that later. I'll come to that in a minute. But before that, this patient is still in emergency room, and this patient is panting away. A respiratory rate of, what did I say, 30, 32, whatever, a minute, and you want to give him some comfort. Yeah. So what do you do in your emergency room? Yeah. Anybody here? DNB? What do you do in emergency room? This patient is really panting away. Do that? Yes, you do that, don't you?
Moist oxygen inhalation.
Moist oxygen inhalation and nebulization. Yeah.
Proper position.
Proper position. You don't do this? Yeah. The last line. Yes, you do. Somebody is nodding. Oxygen. I will come to that later if you ask me a question. And what else do you do? Proper and what else?
Nebulization.
Nebulization. I'll come to that definitely. Now, Derifalin Decadron, we all give, don't we?
Yeah.
And most of the government hospitals, they do. We have to ask ourselves whether we are doing it right. What is Derifalin? It's a theophylline. It's a xanthine alkaloid, and that's been there for the last 50 odd years. Now, when I say 50 odd years, there was no inhaler, there was no nebulization, there was no rescue. Yeah, I also gave it when I was a house officer. Not now. Not now. We have better and much more efficacious drug in the form of inhalation therapy. Derifalin is a theophylline, and it is a weak bronchodilator. In my country, we are poor, and so it is the cheapest bronchodilator available. However, the therapeutic window is very small. You know what therapeutic window is? The amount of drug in your system and the amount of drug which causes toxicity, the gap is very narrow. And our problem in my city or in my country is that we cannot do the drug level. So we have to judge the patient clinically, which is very crude anyway. And this is very weak bronchodilator. It doesn't matter, it doesn't add to your efficacy of treatment if you have facility to give inhalation therapy to the patient. So there is hardly any point to give derifalin injection. It causes tachycardia, and the patient is already tachycardic, as that patient, so heart rate was 110 anyway. So let's think about it when the next time you give derifalin. Don't give derifalin and give the inhalation therapy and see how you go. And I'm sure, I guarantee you, I never have used derifalin for the last, I don't know how many years. Never have. I just go and stop derifalin when I see one. I'm talking about asthma. I'm not talking about COPD, but I'll talk to you about COPD and derifalin if I get a chance later. Degadrol. Yeah, we give Degadrol, don't we? Yes. Now Degadrol, what is Degadrol? Degadrol is dexamethasone, yes? You give betamethasone as well? Betnala tablet? You do? No, dexamethasone. Degadrol we give. Now dexamethasone, what do you follow it up with? You give Decadron and then you send the patient to the ward. And what does he get? Does he get Decadron? Gets prednisolone, somebody says. Yeah, everybody agrees with that? You do. Now, dexamethasone, that's what we have in our emergency department, do we? Dexamethasone, there is a basic difference between prednisolone, hydrocortisone and dexamethasone. Prednisolone, we have to give intravenous, don't we? Otherwise the patient will suffer more. Yeah? The answer is no. Answer is no. Do we know the onset of action of any of these IV steroid? For hydrocortisone it's 5 hours, and that's one of the quickest acting steroid. 5 hours. And if you give prednisolone orally, it starts acting in 8 hours. So there is 3-hour lag. Not much clinically. Because by that 5 hours, you will have given the patient inhalation therapy and the patient will be symptomatically better. Dexamethasone has got other disadvantage. Dexamethasone's hydrocortisone half-life is 3 hours. But when it comes to steroid, it's not just the half-life. We judge the steroid by the physiological activity. How long does it suppress HPA axis? For prednisolone, it's 20 hours. And that's the reason why we can give the whole dose in the morning and forget about it. We have no problem with that. Okay, it's 3 hours half-life, but the physiological activity stays for 20 hours, or in other words, it suppresses the HPA axis for 20 hours. It gets 4 hours relief so that the adrenal wakes up, and then you give the next morning the next dose. Whereas in dexamethasone, the plasma half-life is 3 hours, but it stays in your system and it suppresses the HPA axis for 3 days, more than 3 days. Or in other words, if you give Decadron now and then reinforce that with repeated dosing, you are suppressing the patient's adrenal in the best possible way. I'm asking whether we have alternative option, and there we have. We definitely have. Now, problem with hydrocortisone is that the physiological activity stays much lower. It's 10 to 11 hours. And that's the reason why you give repeated dose of hydrocortisone and get away with it without suppressing the HPA axis unless you continue hydrocortisone for a very long time. Yeah? So, when the next time the patient comes to emergency room and you decide to give derifalin and Decadron, think for a second. And if you have hydrocortisone, give hydrocortisone instead. Do not give dexamethasone. Okay? Somebody said oxygen. How much oxygen do you give to the patient? Yeah, sorry? Any idea? Now, oxygen is a drug. Please, this is not an oxygen talk. That's one of my favorites. Please remember that oxygen is a drug with side effect. So do not overdo it. However, if a patient, that 27-year-old comes who is a non-smoker, never smoker, you can give high flow oxygen, even 100%, not a problem. If I come to you, I'm 85, I've smoked for the last 60 years, and you give me 100% oxygen and go away, come back in half an hour, I'll be dead. So beware. The priority is to correct hypoxia, that's fine. You give minimal dose to correct hypoxia, you need the saturation to be at about 92. For my COPD patient, I tell my nurse, my target is 89 to 92, that's fine. If you achieve a saturation of 89 in a COPD patient, you are preventing tissue hypoxia, and that is all you want, without being into troubled water. So, Dedifalin and Decatron. Any question here? Anybody? So, oxygen, yes, you give oxygen. I can talk about whether it should be moist or not, or dry, but no, I will refrain from that. Prop up, fine, that's good. Now, criteria for severity. I'm coming back to criteria for severity. Everybody is aware of the criteria? I will go back to my patient. Can't speak in full sentence, that's bad. Pulse is 110, that's not good at all. And expiratory bronchi doesn't come in the picture. Okay? And this is the features for severe asthma. Do we do any peak flow? Have you seen what a peak flow machine is? Peak flow meter? Now, whoever is doing medicine, I would urge them to at least hold one of those stuff, a long tube, and it is useful. I'm telling you, it is useful. A peak flow of less than 50% of his best, or if you have a chart, you can see from the age, height, and sex, the normal, and if it is less than 50%, that's bad. Pulse is more than 110. Unable to complete sentence, and respiratory rate. And again, this is what I tell every day, that if I practice chest, or it doesn't matter whether I practice medicine or chest, when I see a patient with respiratory problem, if I do not count the respiratory rate, I'm not doing any justice to the patient, because I'm checking for 10 seconds or maximum 15 seconds. And that 15 seconds can tell me whether the patient can go home or should come in, or whether I should stay there a bit longer, or whether I can just leave the patient on to my registrar. It's very, very, very important. Anybody who's breathing more than 30 a minute has got serious disease. So next time when you check a patient with respiratory problem, please do check the respiratory rate. It takes only 10-15 seconds. But there is another category, it's life-threatening asthma. Is peak flow is less than 33% of normal or his best. Silent chest, cyanosis, feeble respiratory effort, bradycardia, hypotension, exhaustion, confusion, coma, and blood gas. Do we do blood gas?
Yes.
Do we do blood gas? Now, a patient has got that chap who has just come to you, we have done a blood gas on him. What will you be looking for? You have made the patient spend, you don't make the patient spend, I do. In Woodlands, it costs 1,200 rupees. You have to give the money back to the patient, the value. So what criteria are you going to look for in an ABG in that sort of a patient? What is the most important parameter in that ABG?
Hypercapnia.
Beg about hypercapnia, did you say? Yeah, anybody? Anybody else? Any advance on that?
PCO2 and pH.
PCO2 and pH. Can you elaborate on that? What pH will tell you?
There will be respiratory acidosis.
Respiratory acidosis. Okay, why? Because the CO2 will be high? Okay. Anybody else? Anybody? Right. I think you are right in a way. PCO2 is is the most important in a patient who has got asthma, and when you see the ABG report. The parameter is the PCO2. You know why? You don't wait until the patient develops a respiratory acidosis. That's too far gone. That patient needs ventilation immediately. I will call my anesthetist colleague and say, please stand by if I see that the CO2 is normal. You know why? Because the patient is breathing at a rate of 35, 40 a minute. He's washing out he should wash out his carbon dioxide entirely. If the carbon dioxide is in the range of say 20, 22, 23, 30, I'm happy. If I see that the carbon dioxide is 40, I know that the muscle is fatiguing. The patient is going to go off any minute. He might, if I cannot bronchodilate him immediately, the patient is going to go on a ventilator. And so I better warn my anesthetic colleague. Yeah? So that's the ABG. Exhaustion, confusion, we know. We know the moment we see the patient, we know. All of you have seen these patients. Now nebulizer. Yeah? With what? Speak up a bit, because everybody should hear.
Steroids and bronchodilators.
I do not know what a bronchodilator is. You tell me. Sorry? I do not know what that is. You tell me. Salbutamol. Anybody? What do you use? Sorry? Beclomethasone. You have never used that though. Right. Salbutamol. That's fine. I want one of you to stand up and say, what do you tell the nurse? And that's the reason why I wanted a few of the nurses to be present. What do you tell the nurse? And what do you write in your prescription? That's important. I'll come to that. You'll find it in a minute. What do you write in the prescription? Nebulizer? Salbutamol. You don't write salbutamol. You write a trade name, don't you? Doesn't matter. It's good that you have said salbutamol. A few of the MD chest people do not know what the composition of Doulin is, and that hurts me a bit. Salbutamol. So what do you write? How much? I'm a nurse now. How much?
Salbutamol with normal saline in a 1:2 ratio, 1 ml/2 ml.
Which guideline tells you that? Or your Dada has told you, I'm sure. That I have learned quite a lot from my Dada. Anybody else? Any advance on that? I have a point to make. That's the reason why I'm emphasizing on this. I have a point to make. If you write salbutamol, 1 sachet, 1:2 or whatever you write, now I am the pharmacist. There are 2 strengths available, 2.5 and 5. What do you think I will give the patient? I will definitely give 5 milligram. I want to make money. It is up to us to mention which strength we want, whether it is 2.5 or 5 milligram. And I will tell you, I use 2.5 99% of the time, because there is another problem. I'll come to that later if I have to. Give 2.5 milligram. Give the lower dose, not 5 milligram. And this 1:2 thing, are you sure that is the right way? Everybody does it, isn't it?
It's usually 1:1 or
That brings me to that nebulization theory. That's the reason why I wanted a nebulizer tubing, which I haven't got yet, and I forgot to bring one. Have you ever used it? No, এটা শুধু oxygen mask. দিয়েছে? হ্যাঁ, দিয়েছি। Have you ever seen this? Have you held it in your hand ever? Please do, because it doesn't matter. We all should know how to wipe the floor. From wiping the floor and to treating the patient in ITU, we have to know everything. Otherwise, we will be caught out. Please, next time, you do it yourself. You will learn plenty of things. I'll tell you what. There is no guideline saying 1:2. The guideline is, on the ward, we cannot follow the guideline properly, because every nebulizer, we use jet nebulizer. There are 2 types of nebulizer. One is jet, Other is ultrasonic. We do not use ultrasonic nebulizer. The nebulizer that we use is a jet nebulizer. And jet nebulizer, the company should tell us what is the residual volume. Residual volume meaning, at the end of nebulization procedure, there is always a bit left. And that volume determines how much the fill volume should be. Fill volume meaning, what you said, 1 milliliter and 2 milliliter, or 2 milliliter or 3 milliliter. That we do not know, but usually it is 4 mils. Usually 4 mils. So usually the respule is about 2 to 2.5 mils. Okay? And so you can dilute. The guideline says you don't have to. If you do not have the diluent, normal saline or distilled water, do not give, it's Christmas Eve, give neat, all right? And you will have no problem. Next, I'm a nurse, okay? And the patient is 85-year-old, I have come to you, and I have been smoking for the last 60 years, and you have given me nebulizer, and you said, all right, 2.5 milligrams salbutamol, and you have left. You come back in half an hour to find me dead. You know why? Because your prescription was incomplete, and you take the whole of responsibility of my death. Because my son is coming to take your pants off. You know why? Because I'm the nurse now, and you're the doctor. You have given me a prescription, salbutamol. Give salbutamol. And I have given that COPD chap, 85-year-old, Dasgupta, 10 liters of oxygen. That's what it needs. Between 6 and 10 liters of oxygen, you need to nebulize. Okay? 6 to 10 liters. Did you know that? Yeah? Now, if you give 6 to 10 liters of oxygen to a patient who's suspected to have COPD and you do not know the carbon dioxide parameter, whether the patient is hypercapnic or not, and you go away, go ahead, you don't. So tell the patient, if you even suspect that the patient can have hypercapnia, tell the patient to nebulize with machine or air. Do not touch the oxygen bit. But I'm talking about asthma. This chap, he will have absolute no problem with oxygen. It's just a word of caution. Is the prescription complete now? I have written 2.5 milligram of salbutamol, neat, or another 1.5 mils of normal saline, that's 4 mil. For ITU and ventilated patient, you have to fill the container should be full. And I'll come to that later if you ask me. Is the prescription complete? 2.5 milligram salbutamol via machine or oxygen, whatever. This patient oxygen. How long for? I'm a nurse now. You haven't told me that. I've got 10 patients to see. So I go away, leaving the nebulizer mask on. You haven't told me when to come back. I'm waiting for that chamber to be dry. How long do you think the nebulizer should continue? One episode of nebulizer should continue. How long? What do you say? Now, please make sure, and this is why, I was calling the nurses. The nurses should know, and we are the ones who should teach them. The guideline is between 5 and 10 minutes. Always should be less than 10 minutes. It's up to 10 minutes. No more than 10 minutes. And there will be a bit left. Throw that away. That's the residual volume we are talking about. We cannot make it dry. So maximum of 10 minutes of nebulization. Okay, and if you have a COPD, make sure that the patient gets it through machine and not through oxygen. So with what? And you said beclomethasone, we do not use, I don't think you get beclomethasone and respules, you get budesonide. I'm pleased that you didn't stand up and said the trade name. It sounds odd if we go on talking about the trade names and do not know the composition. So budesonide, yes. How much? I'm a nurse now. I'm a pharmacist. I run a pharmacy. You ask for budesonide, I'll give you the bigger one, naturally. But do you want one? So make sure that you know the dose. Otherwise, there's no point. It's available in 0.5 and 1 milligram, 500 mics and 1000 mics. Okay? So you have now got, which one will you choose? 0.5 or 1?
0.5.
0.5, fantastic, very good, I like it. So you have chosen, so you mix it with everything, a concoction. It doesn't matter whether you mix or, usually the consistency is different. But you can mix, but whether you need to. That's my question. That's my question. Every time asthma comes, we give budesonide nebulizer, do we?
Yes.
Yes. Have we checked the evidence behind it? Have we? The reason why I'm saying this, and everything has got a point. The reason why I'm saying this, the patient is, you have given him a whopping dose of systemic steroid through his vein, haven't you? You have given either Decadron, which you are not going to give anymore. You are giving a whopping dose of hydrocortisone, 200 milligram immediately, stat, and then maybe 100 milligram 3 or 4 times. That's the maximum dose, 400 milligram a day. So you're giving a whopping dose of steroid systemically, whether there is any point of giving inhalation steroid. And I'll tell you no. From tomorrow, do not give inhaled, nebulized steroid when you are giving the patient a whopping dose of systemic steroid. There is no point. There is no added advantage. Okay? You are not only making the patient spend more, I'm coming on to that every time. Your patients don't spend, but my patients do. But also, you are subjecting the patient to all the side effects of steroid, local side effects. Cataract, because, and that brings me to that point. This doesn't have it. Now, when you are nebulizing a patient with either, do you not use ipratropium? Do you? And you use budesonide as well. I want you to check the nebulizer, these things, tubings, today. Please do. Because you will find there are few, I hope there are one or two, that there are mouthpieces. Have you ever noticed a mouthpiece in this packet? A mouthpiece is a flat white thing. When you give budesonide, that whopping dose of budesonide, 500 mics or 1 milligram, and you put a mask on, the mask most of the time is loose, and so all the fume or the plume, they go not only at the face, facial skin, but also to the eyes. That's the best way to give the patient a cataract, if you continue that. Now, the guideline says that we should use mouthpiece when it comes to either nebulized steroid or ipratropium. What is I don't know how long have you been practicing nebulizer? Must be a few years, not like me. I've been practicing it for the last 60 years maybe. What is the common side effect that your patient told you when you are giving ipratropium nebulized? No? If you ask the patient, they will possibly tell you that their vision becomes hazy after that. You know why? Because you are dilating the pupil with anticholinergic. Okay? And so, even with ipratropium, we should use mouthpiece and not the mask. Okay? So, Buricort, when you are giving, I have written the name, because every time, everywhere I ask, everybody comes up with the name, the trade name. And I'm very glad that you haven't. How long? I have already told you. No more than 10 minutes. Please write it. and practice for 2 or 3 occasions, and then you'll be okay. With oxygen, yes, when it comes to asthma, pure asthma, then oxygen will have no problem, you will have no problem. But when you suspect that the patient can have COPD, you give oxygen through the nasal cannula. That's not a problem. Okay, 1 liter, 2 liters, just to keep the saturation above 90. Fine. And then give the nebulizer through machine. I'm not boring you. No, thank you. Is spacer any good? This patient has gone to the ward now. Okay, this patient has gone to the ward, and now you have come to see the patient. The patient is feeling better. Patient is feeling better, and you auscultate the chest, and it is, there are plenty of wheezy sound, the expiratory bronchi, but the patient is feeling better. What are you going to do now? Pat the back and go away? Are you going to do something? No? Skip this. Are you going to give some antibiotic? No?
Yes.
Why not? No? No? Are you going to give some antibiotic?
Yes.
Yes. What antibiotic are you going to choose? Which antibiotic? We do it every day. You do it every day. So don't be shy. Just tell me. Sorry? Go on. Respiratory? Fluoroquinolone. Yeah? Did you say respiratory fluoroquinolone? Did I hear you right? No? You didn't say that. I heard it wrong. Must be. Anybody?
No antibiotic.
No antibiotic. That's one option going on. Any advance on that? No? The patient has got pure asthma, you do not need any antibiotic, absolutely right. But quite often we give because we are not sure whether the patient has got infection or not. If the patient is in hospital, we are in a safe place, not a problem. I wait for the chest x-ray and the blood to decide whether the patient needs antibiotic at all or not. And I wait. In the community, it becomes slightly dubious. If you have to choose antibiotic, when you think there possibly is a chance of infection, what antibiotic? Protect the patient from streptococcus pneumonia. And we can get away with just a penicillin. I choose amoxicillin, and I get away with it in the community. Yes, there are plenty of resistance. Yes, we are one of the countries where there is highest resistance, about 22-25% of pneumococcus resistance. But I tell everybody that there is 75% which is sensitive. Why always we should choose respiratory fluoroquinolone, which is a broad spectrum antibiotic. Okay, and for me, it's very difficult to accept that because I use that for second line TB treatment. So I don't want to expose the population to that as much as possible. So amoxicillin, doxycycline, even a cotrimoxazole if you want, they're all acceptable alternative. But yes, you can use respiratory fluoroquinolone. Of course you can, but that comes way down. And that if the patient is moribund, yes, of course. In ITU, we use a lot of antibiotics that we never use outside. That should be the motto. And the narrowest possible spectrum of antibiotic we should choose. I will come to the spacer in a minute. Antibiotic, which one? How long for? How long do you use antibiotic? Yeah? Anybody? Come on. You use it every day.
5 to 7 days.
5 to 7 days. You know why? When I became a registrar, and we had to have a research stint for 1 year. You had to do some research work. And I went to join a new hospital, and the consultant was like Einstein, white hair, all these things, and then he was surrounded by about 10 people. And I walked in and he said, asked me the same question. How long do you use the antibiotic? And I said 5 to 7 days. And he asked me, why? What is your evidence? And I said, that's the convention. He said, that's as much evidence as you've got. You know why? Because you have got 5 fingers in your hand, and there are 7 days a week, and that's all the evidence that we have got. We had in 2005 a BMJ article from Lucknow, King George Medical College. They showed in pediatric population, community-acquired pneumonia, 2 groups were selected. Large study, 1,000 on each group. They used 3 days and 5 days of amoxicillin, and both were 90% success rate. So 5 days fine. IV or oral steroid? I think I have answered that question. If the patient's intestine is fine, not vomiting, the patient is not too bad, can swallow, prednisolone is fine, not a problem. That will keep the cost down. How long? That's a pertinent question. How long do you use the steroid? Sorry? Oh, I'm absolutely deaf. Speak up, please. Sorry? Sorry? How many days? From when? How long will you give the full dose? And what is the dose that you give? What is the dose do you give? Prednisolone?
2 milligram per kg for 14 days.
So I'm 70 kilos. You give 140 milligrams?
No, maximum 60.
Maximum?
60.
Right. Okay. Any advance on that? 60 milligram. What do you use? How much? Come on, don't be shy. Sorry. The recommendation is 30 to 40 milligram. Okay? And that should be given between 7 and 14 days. And some of the books say 5 to 7 days. That's okay, but 7 days usually. Okay? So how do you stop it? Somebody said tapering it off. Do you always taper it off?
14 days it's
How to
not
stop?
required.
Do you pardon?
Till 10 to 14 days
Yes.
it's not required.
Not required. And the studies show that it can be, but that's the range is 7 to 14 days. How do you stop it? Do you always taper it off? You don't need to. Even if you give 3 weeks of steroid, you can safely, but it has to be not more than 40, less than 40. If you give more than 40, it has to be tapered off. If you give for longer, but if it is 30, you give for 14 days, you can abruptly stop it. Not a problem. There are a few things that you must remember. If the patient has had oral steroid for a very long time, then the patient it should be tapered off. If the patient has got adrenal failure for any reason, it should be tapered off. If the patient had a systemic steroid course in the last 1 year, you should taper it off. So, so those are the things.
We have there is one thing. We have started using methylprednisolone now in the acute setting as well as a follow-up.
Any particular reason why? I will tell you. Thank you for raising that issue. I use hydrocortisone and hydrocortisone only. Why? The Americans use methylprednisolone and methylprednisolone only. In the UK, up and down the country, they use hydrocortisone. Reason is hydrocortisone is cheaper, much cheaper than methylpred, and does the same job. Methylpred, the only advantage theoretically a bit is that it has got less mineralocorticoid activity. Or in other words, the chance of hypokalemia is slightly less. I've got bottle syrup, not a problem if I have to give. And when you give a short course, 7 days, I keep in mind what the cost is and whether I'm getting any added advantage in methylprednisolone. Methylprednisolone has got another advantage, theoretical, that it penetrates into the acini a bit better, and so theoretically it possibly has got better role when it comes to my interstitial lung disease patient, not clinically proven. So it's theoretical. So no, I stick to prednisolone and hydrocortisone. But yes, I won't argue if you use methylpred. So I think we have discussed this already. No. When the patient is on the ward and the patient is getting better, when do you discharge the patient and how? Is it, the time is up? Shall I stop? I can stop anytime, not a problem. Please, I can stop. I lose the track of time. How do you discharge the patient? The patient is getting better. So how have you? We do we audit our wards? What is going on? What are we doing?
Yeah, we have.
We do. So what is your average length of stay for an asthma patient?
It depends on the season. In winter season it is prolonged, in summer season it is less.
5 to 7 days.
I said average.
Average 7 to 10.
5 to 7.
Right. It's about 5 days, isn't it? 5 to 7 days. It should be 5 days. Fine. How do we discharge? Do we have a protocol that we follow to see that the patient is okay? And again, the role of peak flow meter will come in. Please check the guideline. It's all over. It doesn't matter. The peak flow plays a major role, and it's very cheap. And the patient takes it home, and he or she can use it for the rest of his life. Not a problem. And the patient must be better. There should not be any confusion. There should not be any dips in the peak flow. The patient should be mobilizing well. No nocturnal symptom. All sorts of things. Yeah, that's fine. But there's a set protocol, especially with peak flow, and the peak flow is very important for that. When we discharge the patient, when we see the patient on the ward, and the patient is getting steroid, do we use anything else? I said stop the Budicort or budesonide nebulizer. Do we use anything else? Do you prescribe the inhaler? Then, when do we prescribe the inhaler? When the patient is going home?
There should be a overlapping.
There is a point I want to make. That's why I'm asking this question. The reason why I'm asking this question is that this patient should have inhaled corticosteroid inhaler. Earliest opportunity. Why? On one hand, I'm saying stop the nebulized steroid. On the other, I'm saying please give the inhaled corticosteroid as soon as possible. Why? Because of what Dr. Dasgupta said. There must be an overlap. Why? Because the inhaled corticosteroid at that dose, it starts acting after 6 days. So 6 days or 7 days of steroid should be overlapped with that inhaled corticosteroid. So when you stop the oral steroid, the inhaled corticosteroid has just kicked in. Yeah? Now I won't go into that. For a pregnant lady, all I have to say, and I will finish with this, that treating a pregnant lady is no different than treating a non-pregnant asthmatic. So use whatever to keep the patient comfortable, because if the mother is breathless, so is the baby. So all are okay. Do not try to refrain from Montelukast. Possibly it is safe, but we do not have enough data. Okay? And I do not use theophylline in asthma at all. Thank you very much. And I will take questions if you have any.
The role of spacer you haven't.
Oh yes. And do we use spacer?